Broadcasting from the campus of Salisbury University, this is WSDL Ocean City, NPR Newstalk 90.7, putting Delmarva first. It's time for Delmarva Today with your host, Don Rush.
A second Texas nurse has tested positive for Ebola, and as the disease takes more lives in West Africa, the Centers for Disease Control is working with hospitals to deal with the unexpected turns of the outbreak. Welcome to Delmarva Today. This is Don Rush. Amber Vinson has been identified as the second nurse to have contracted the disease after Nina Pham, one of more than 70 staff members who cared for Ebola patient Thomas Duncan at the Texas Health Presbyterian Hospital in Dallas. Duncan died on October 8th. Since then, the Centers for Disease Control has been looking at the protocols for hospital personnel who treat Ebola patients. Meanwhile, screening has been tightened at a number of U.S. airports, and the president has canceled a campaign trip to huddle with his team on the Ebola outbreak. In our studios, take a closer look. We have C.D. SILVIA, who is the Chief Medical Officer at Peninsula Regional Medical Center, and we appreciate you stopping by.
Happy to be here this morning. Thank you.
Well, let me first of all ask you, just a personal question, were you surprised at how this outbreak has flourished? I mean, obviously we have the situation in West Africa, which is beyond anything that we've seen before. And then we're just seeing at least one individual case with a couple of nurses, at least for the moment, and certainly a reaction by the U.S. government as well as the hospitals. How do you assess it? What was your reaction as you saw this story unfold?
Well, Ebola has been around for a good while, and but so far, luckily, it's just been pretty much isolated to Africa. But you would think that with our international travel, it's just a matter of time before it would become international. The current strain that's out there's 5 strains of Ebola. This one's a very nasty one and makes it more virulent to be able to infect people more. Unfortunately, that's what we're dealing with. But not surprising, but again, trying to be prepared for something that was very, very unlikely to happen. And of course, we have so many other things that we have to take care of. That we try to prepare for everything, but there are so limited resources. But also the CDC, who advises us on how to deal with these things, probably was a little behind in a lot of this, and are trying to catch up very quickly. And we're following their guidelines as best we can.
Well, why do you think that we seem to be a bit off guard? I mean, we've talked about preparing for this. I know Doctors Without Borders, for instance, deals with this a lot.
Right.
I saw someone the other day who observed that they have a fairly good track record in terms of protecting their people, even in a situation that certainly is much less modern than what we're looking at here.
Well, if you could go back and kind of do it a better way, it would have been nice for the CDC to have all this figured out ahead of time using the experiences of people. Of course, West Africa is much different than the United States on their level of care, their number of doctors per patient, their ability to take care of somebody critically ill. So it's a big difference. But it would have been nice to have all those protocols, all the protective gear already figured out ahead of time so that could be rolled out very quickly. It seems that we are in a process of learning. I think the CDC is learning as well and adjusting their recommendations as seems almost every day, and what they're planning on doing. So we're doing our best to keep up with it and then bring it to another level to be as extra safe as we can. But there's very many other things. I mean, the flu. The flu is in town. We've had a few cases already, which is unusual this time of year. That, as far as the country is concerned, is a much more serious disease, and more people are going to die of the flu than Ebola by many times over in this country this year. And just trying to get people to get a flu shot, is tough. There's lots of things that we have to manage, and this is just one more added to us, but a very serious infection that we do take very seriously.
Well, let's talk a little bit about probably certainly the concerns of a lot of listeners, which is how is it, what is it, and how is it transmitted? How easy is it to get this disease?
I think that's still a little bit up in the air. We do know that it's, you have to be exposed to an infected person's bodily fluids, and that could be their blood, their stool, secretions of some sort, and then you have to have that exposed to your mucous membranes for it to get into your body. But it is very virulent, so it doesn't take very many particles of the virus to do its job compared to a lot of other viruses and infections. We take care of infections every day, all kinds of infections that are very dangerous. This one just seems like it's a bigger one than usual than we've had to deal with, and because it is much more virulent, the level of protection has to be much more aggressive, let's say. But we have used gowns and gloves and masks and things for lots of infections for many years and know how to do that. This is just a different level. And between the material that's needed and the gowns and the special things that are needed, there's already starting to be shortages of that in the country because everybody's ordering it, and again, weren't ready for such a thing. And the CDC, as they've kind of changed their guidelines a little bit on what do we use, and then it's a little, well, let's add this to it, and let's add this to it, and the type of gowns that are used, and to a full-blown mask, gown, almost like a spacesuit, kind of thing, which they haven't recommended yet, but it seems like we're moving towards that, because you want to protect every part of your body. The key to this is protecting yourself, but also when you take this stuff off, that's where they worry about people infecting themselves, because you have to be very careful that if you have fluid on your body on these protective garments and then you take this off, could you expose yourself while you're taking it off, and then infect yourself or others that way. So it's very important to know how to do this properly, and that's where we're at now, is training our staff, and we are trying to focus on a smaller number of staff that can be the experts at this, and focusing certain areas of the hospital, certain staff of the hospital to be the experts to take care of. If we ever get a patient, we could, you never know. Texas didn't think they were going to get one either, but to be ready and have the proper people that know what they're doing, and that continually training, doing drills, practicing, is very important. You can't teach 5,000 hospitals and thousands and thousands of physicians, nurses, and other staff to do all this at one time. And you probably don't want to in the beginning. You want to focus on certain people to cover this and do it the right way.
Because, for instance, in the case of the hospital in Texas, we've had the I guess it's the National Nurses United Union talk a little bit about what they've been told, including obviously some things obviously have been corrected, but some of them worked without protective gear. The Duncan himself was in a non-quarantined in a zone for several hours where there were patients. Some of them were not using masks, or some of the nurses were told, well, use tape in order to cover yourself. And I know the CDC, when it deals with Ebola, it goes the full 9 yards. It's got the whole sort of space suit kind of thing. There seems to be that sort of protection, and then there's the protection that at least they're talking about inside hospitals. I mean, is there two approaches here, or is that evolving? What are you hearing?
You kind of feel sorry for the Texas hospital, because I think they were kind of a sacrificial lamb. Again, they're a normal hospital, and normal hospitals weren't ready, for this when the first case came, and they were just the unlucky ones to get it. And they were doing a lot of their normal procedures and trying to step it up, but probably not doing it as well as they should. But were doing what they knew how to do at the time. Again, the things have changed. The guidelines have changed since then and are continuing to change. So we're learning. Unfortunately, somebody is a guinea pig to learn on how to do this. But no, the country in general was not already waiting for Ebola to come. It was, oh my goodness, let's get started, and some hospitals are ahead of others. But again, it talks about resources and all the other things that we're trying to take care of that are here, that are realities versus the possibility. But now it's a reality too. But again, having the state, the national recommendations, the funds to do a lot of this. A lot of hospitals struggle as it is, and it costs money to buy all this stuff and do all these extra things. A lot of the equipment and things that they use on a person that has Ebola has to be destroyed. You can't just wash it and use it on somebody else. So it's going to be a big outlay in time, in money, and resources to take care of these people. And like I say, the hospitals struggle to start with. But they are working on it. They are trying. I know every hospital takes this very seriously. And the CDC, again, they keep changing. They tell us now they will send out a team within 24 hours once there is a diagnosis. Now, it takes sometimes a few days to have that diagnosis, and the way they govern this is that we have to have permission to order the test for Ebola. So we have to ask the state health department, is this a person that's reasonable to do this? And they tell us yes, and then we can get that done, and then usually within 24 hours we'll have a result. Well, that process from the time somebody walks into our emergency room till that's diagnosed could be a couple days, that we have to be ready to treat that person as if they do have it. And then once they have it, then they say they will send people, experts, to help us. But we've already dealt with it for a few days, so the danger could be there if we're not ready. So the way we're looking at it is that we are going to be ready and be able to take care of this on our own, and we have to. They're talking that maybe, depending on how things go, maybe that they'll have us send people, the patients, to certain areas. There's certain hospitals in the country that are much more well equipped for this. Probably the University of Nebraska, probably the number one, but the total number of beds in those places is small.
Pretty limited, yeah.
Yeah, it's maybe 20 or 30 beds total, I think, from my understanding. So if we do have a big outbreak, they're going to be overwhelmed. So if it's shut down, and hopefully it will be, as we learn how to limit the exposure, once one person comes in, and not have them go out and infect many other people, that we can contain it to just a few patients, hopefully, that kind of slip through the travel issues and can deal with it that way. But again, we feel like we have to be ready. We have to take care of our population, and because we're at the front line, and
Let me ask you this, because you're talking about a patient who comes in. I mean, obviously in the case of Duncan, and certainly the hospital wasn't quite prepared, but he was like a couple of days. We also know, by the way, that he was sent home and they came back and so on. If somebody's going to your emergency room, or even in your hospital, and they show up, I mean, how do you know whether or not this person sitting in your emergency room, waiting room, may not indeed have this? And then how do you protect? I mean, how do you deal? What's the protocol?
It's complicated,
here, you know what I mean?
and like I say, and it has been developed. What we are doing now, we have signed that when you first walk in, if you've had any travel history, tell us right off the bat. If there is any travel history that would make us think that you could be a person that may have been exposed, or if you have certain symptoms, then we automatically will say, okay, we're going to prove that you don't have it rather than that you do. So they will be put in a isolation area and triaged. Our staff will be protected with the proper clothing, and then the workup will occur to decide whether a person is a high risk versus a low risk, and then if they need to be admitted, then they will be placed in a certain area, a certain room in the hospital that will be designed just for this, with a staff that's trained just for this, and taken care of. So unfortunately, you're going to have a lot of false alarms. A lot of people just like anything will be, gee, maybe I have Ebola, and it's going to be tough to sometimes weed out all those people that, think they might have it and have no risk, or maybe have a small risk versus somebody who really has a risk. But say we're going to err on the side of caution. We're going to treat them as if they do, and then prove that they don't. Usually, within, if they, and again, you don't test everybody just because they walk in the door. There's criteria that are designed on who do you test and when do you test them, and then if they are positive, okay, we do it one way. If they're negative, okay, well then we're good. But there may be some observation time where we have to see how they do. This isn't something that's going to smolder and you have for weeks and weeks. Once you start having symptoms, once you start having fever, it progresses pretty rapidly without any treatment. So we'll know, pretty quickly. But again,
I was going to ask you, because I was going to ask you. I mean, we mentioned a moment ago that we're sort of entering the flu season. Lots of people getting shots, and I looked at the symptoms. Right, we're talking about headaches.
It could be anything. It's not just. Having abdominal pain, having a cough, having I feel bad. I got some muscle aches. Gee, that's the flu. Having a fever, that's the flu. And like I say, if you bet on somebody that walked in our ED today, you would bet flu or some other disease many, many thousands of times more than you would Ebola. And that's the problem, is that it's not that specific, especially in the beginning. Once they're full-blown and sick, that's a different story. But people don't show up full-blown sick usually. I don't feel good, but how many people come in our ED every day, come to a regular doctor's office every day? I don't feel good. I got a fever, and it's not this. That's the struggle we have. But the travel history is our first way of triaging, that had you been somewhere or have you been exposed to somebody that's traveled. That gets kind of tricky, and you could have flown on a domestic flight, but somebody else got on the plane, say from Africa, that then went to Europe, that maybe went to Philly, and then got on a plane that you got on and rode with you, sitting next to you. I was never in West Africa, but somebody in my plane was. And that's the difficult part of, you could have been exposed and didn't even know it, so that's where the questions come in, that you have to ask the right questions.
Let me ask you this about the airplane. So how concerned should people be about taking this kind of accommodation with the airplane or whatever? I mean, is it all that easy to, as far as we know, to contract this?
Again, if somebody is very ill, okay, and their secretions, because they'll usually have diarrhea, they'll have vomiting. I mean, when you're sitting next to somebody on a plane, and of course, how many people vomit on a plane from air sickness versus, but if you're sitting next to somebody that's vomited and you get that material on you, or diarrhea or whatever, then there's an exposure potentially. Sitting with somebody who is in the early stages that doesn't even have a fever, your risk is very low. You have to get those secretions on you. But again, just because you have a stomach ache or diarrhea or vomit, that doesn't mean you have Ebola, And I saw where they had diverted a plane because somebody threw up, and it's like, well, they're air sick, But that's the hysteria, I guess. But also we're trying to be cautious, because if it was that, you're in an enclosed area with a bunch of people, but you're going to get the flu a lot faster on a plane sitting next to people coughing and sneezing than you would get this, but there is a risk, so do you tell people not to travel? I don't know. They're talking about that now, about restricting travel and things, but that's a governmental, world issue, not a Salisbury issue. Thank goodness.
Well, so what do you tell people if they start experiencing some of these symptoms that they might be a flu, but then again they might not be?
Again, it's all about the travel. If you've been exposed to somebody, and we were just talking this morning, that if you have that travel history, or you think you might have been exposed to somebody, and have some symptoms, we would prefer you not go to the doctor's office. Come to the emergency room, where we are trained to know what to do. most doctors' offices, God bless them, aren't. They just don't have the resources to deal with this. Although they're going to start asking the travel questions when a person calls up, hey, I feel bad, I got a fever. Offices should be asking, well, have you had any travel? Have you been somewhere, or maybe you've been exposed to somebody? And if that's yes, he said, well, you probably shouldn't come here. You should go to the emergency room. Probably is nothing, but that's the way to try to limit the exposure to people. The doctor's office can't have everybody gowned up all day long, and so we want to, again, we have trained people to do this and be very good at it, and they are continuing to learn every day. We're teaching more and more as we learn more and more about this, but so we are becoming experts. I think hopefully all hospitals are, but again, it's a lot of hospitals that you got to train, and they all don't have the resources that even we have. But we consider ourselves the leader in this area. People count on us for everything, and we're going to take care of them for this too.
I guess right, because as I read some of the symptoms, there's a fever, but they also get headache, joint, muscle pain, I guess, sore throat, severe muscle weakness. So people should kind of assess, I suppose.
Again, if you haven't been to some of those countries or been exposed to somebody who has been, then you probably don't have Ebola. You have something else, and again, if you bet it, by and far, you have something else, whether it's a flu or some other virus or who knows what. But again, we are going to be extra cautious, and as this settles down and people get better at it, and as the government and the state, both get a handle on this as well, because they're all learning too, then hopefully we will have it even a better process. But there are lots of people working very hard on this, and everybody's taking it very seriously.
Now, I understand that Ebola is actually a fairly fragile virus in terms of getting out of the body. Apparently it can be destroyed by UV light, disinfectants, it dries out there. So it sounds like it's fairly difficult to transmit. And we don't know.
Yeah, I'd say unless you're sprayed with the stuff or it's on your clothing. I had heard that the patient that died in Texas, the walls, the ceiling were covered with diarrhea. It was everywhere. So if you're exposed to that and it's sprays all over you, if you're not totally protected and your skin gets or you take the gown off and as you're taking the gown off, it got some on your hands and then you didn't wash properly, or I touched my eye or my mouth or something, which we do,
Right.
Then I inoculate myself. So there's where the worry is. But just, sitting across like this and person's not very ill, your risk is very low to get that.
By the way, what kind of level of your nurses and doctors, particularly the nurses who are on the front lines, what kind of protection, at least that you're looking at, in terms of the kind of clothing? Obviously we have the extreme, which obviously is a sort of the spacesuit CDC thing. Right. Where are you in that continuum?
We are following the CDC guidelines. Like I say, they do change a little bit, and as almost every day it seems that they're, well, what about this and what about this and what about this? We're trying to be a step ahead. Thinking that they're going to a certain direction.
So how much are they covered?
And
at this point?
we have ordered some of the more aggressive, we'll say, suits and things. We do have our current protection gear, which is what they recommend.
Mm-hmm. What does that consist of?
It consists of the gown, gloves, mask, and a face shield. But like they said, your neck's, could be exposed. And it's, again, more in taking it off than being exposed while you're taking care of a person. But we are investigating even further to try to cover, and say we're ordering stuff that's not right now recommended, to try to go to another level to protect our people as best we can. But we are going by the current guidelines on what they say.
By the way, what is the mood of the hospital like? I mean, I know that we've obviously heard from the Nurses Union, right, who's expressed real concern. Obviously, they're looking particularly at the situation in Texas, which is not everybody.
Right.
What is the atmosphere like, and particularly for the nurses? Is there anxiety? What's going on there?
I think yes, there's anxiety everywhere. I mean, nurses, doctors, all the rest of the staff, they're people too, and if you work in an area where it's going to come, if it does come, then your potential of being exposed is a lot higher. But that's for any other disease that we take care of. So, yeah, it is a little scary. I mean, when the HIV, was first started, same idea. I mean, people were scared to death. But we learned how to take care of that. And we are learning how to take care of this too. And again, if you follow the procedures properly, you won't get sick. And a lot of the people that have taken care of these people, if they do it correctly, don't get sick. It's when you don't do it, or you think you're doing what you should be doing, or maybe don't understand it as well, and then make mistakes. Not because you're bad, not because you're stupid or whatever. It's because I thought I was doing it right, and they didn't have the training to do this. And that's, I think, where Texas got into trouble, is that we tried our best, but we just didn't have all the protocols going and all the training and all the how do you do this, and we're learning, unfortunately, from their trying to do the best they can, and it's a shame they've gotten such bad press because they were just trying to do the best that they knew, but apparently that wasn't good enough, and so we want to try to be ahead of that. If ever a case comes here, that we would be ready as best we could for this, but it's a bad disease, so and unfortunately the treatment's not very good either, other than supportive care. A vaccine is what we need. Of course, that takes time, but there's no good. They've tried some things, but experimentally, but there's no antibiotic for this. There's no medicine for this other than supportive care. So your immune system has to fight this off. And if you get good supportive care, and that's what we're hoping for in the United States, because of our level that we can take care of people much better than they could in West Africa, that many more people are going to survive this than would there when they don't even have IV fluids or, ICUs or, all the training, and don't even have a doctor half the time. By the time they show up to get help, it's too late, because it's the diarrhea and the dehydration that that then causes kidney failure, and then it's fatal. So we feel that the death rate will be much better with good care than it is over in Africa.
Let me just ask one other question about media coverage. Actually, it was a Shepard Smith who apparently said this on Fox News. He said you should not have concerns about Ebola at all, none, I promise. He goes on to say, do not listen to hysterical voices on the radio and television, or read the fear-provoking words online of people who say and write hysterical things are being very responsible. He says we do not have an outbreak of Ebola in the United States, nowhere. We have 2 health workers and who have contracted it from a dying man. They are isolated. He's saying, how do you assess the media coverage of this?
Well, I hate to say it, but I think it is sensational. It does make news, and it is scary, and that's what we have to hopefully counteract. And what we are trying to do for our staff and for everybody here in our community is that we promise to take care of this as best as we can. It's not the catastrophe that everybody's talking about, but we're going to make sure it's not in the future. But yeah, we'd rather go by facts and not have people say things that aren't true or exaggerated. And but that's the good old USA, But what we hope to do and will do is to try to communicate what we know between the health department and PRMC, at least for our area, to educate the population, to tell them what we're doing, to try to waylay their fears as much as possible, and let's just get about our business, and because there's lots of other things we need to worry about too, and we want to take care of our people as best we can.
We've been speaking with C.D. SILVIA. He's the Chief Medical Officer for Peninsula Regional Medical Center, talking about the outbreak of Ebola, and we appreciate you stopping by and talking with us.
Thank you. Appreciate the time.
This has been Delmarva Today. I'm Don Rush, and thanks for listening.
This has been Delmarva Today, a production of Delmarva Public Radio. Chris Rank produces and is our audio engineer. Don Rush is your host. For podcasts, visit our website, delmarvapublicradio.net, or subscribe to the Delmarva Today podcast in iTunes. Delmarva Today can now be seen on PAC 14. To view the schedule, visit the Daily Times or visit pac14.org.